Thanks, Ben. Thank you. So we're going to quickly look at examination of the spine. Basically, it's the pain. Where is the pain coming from? Is it mainly in your back or neck, or is it in the arm? If it is a degeneration, if it is just wear and tear, quite likely it will be an axial pain, that is pain in the neck and pain in the lower limb. When there is a degeneration, so the discs are like a jam donut. So when the jam donut is bad, you will have neck pain and back pain. But if the jam donut, the jam has come out to the jam donut, then it is going to hit on the nerve that is going down into your arm or into your leg, and then you have arm pain or leg pain or the radiculopathy. So I try to find out from them whether which part of the pain is more. If divide your pain between your arm and your neck, or between your leg and your back. 80% in the back, 20% in the leg, unlikely to be a full disc prolapse, more like a degeneration which is causing some irritation. Whereas 90% of the pain in the leg and only 20% in the back, then more likely it is a disc prolapse that is causing. The jam is hitting the nerve. And then obviously other things, whether there is night pain or what are the aggravating and relieving factors, how to differentiate between vascular and neurological claudication. Night pain, and someone who's severe pain at night can't get to sleep, we have to worry there is a malignancy or a secondary cause of pain. Because any person, even with a disc prolapse, you should be having some rest, some sleep when you lie down. If it doesn't, then that is a red flag and it needs investigation. Then about what are the aggravating and relieving factors. Mainly for vascular and neurological claudication, they walk a certain distance, they have pain. But in vascular claudication, they walk a certain distance, they can stand up and the pain will get better. But in neurological claudication, if they walk a certain distance, they'll have pain in their legs, but they have to change the position of the spine. Only then will they get better. They have to sit down or crouch forward to change the position of the spine, and that is important. And that's how we differentiate between vascular and neurological claudication. Vascular claudication, smoking history, and the arteries are clogged. Whereas in neurological claudication, there is a spinal canal stenosis in the lumbar spine. You can stop me if you want, you don't need to wait till the end. Then gait, how are they walking, whether there is any sensory loss, whether there is dysesthesia. When there is irritation to the nerves have an heightened awareness, and that is dysesthesia. Fine motor activity, I will show you some examples, happens in the upper limb when you have myelopathy. So there are two terms, I'm sure you know, but just to refresher, there is myelopathy and radiculopathy. Myelopathy is when the spinal cord is affected, radiculopathy when the spinal nerve roots are affected. So if the motorway is affected, it is the myelopathy. But if the A roads coming from the motorway is affected, it is radiculopathy. So when your motorway is affected or the spinal cord is affected, then you will have difficulty with fine motor activity, turning keys, counting coins, writing. These are the things that you will have difficulty. Bladder bowel disturbance, we are looking for is an inability to pass water. But there is now a lot of change in definition of what is a cauda equina syndrome. I don't want to dwell too much into it, but a full-blown cauda equina, so there are 3 stages cauda equina syndrome in retention, which means there is retention, the bladder has lost its function. They say we have missed the bus. So it is earlier stages of cauda equina we need to find out. There is cauda equina syndrome incomplete. They have difficulty emptying, or they have numbness around the saddle area. But if they are peeing 20 times, they don't have cauda equina syndrome. They have just drunk too much last night, that's all. So the single line definition of cauda equina syndrome is paralysis of the pelvic viscera. So they'll have difficulty pushing out their water and their bowel. So if they are peeing a lot, then it is not, cauda equina. So as in any examination, orthopedics is simple: look, feel and move, and that's with the back also. So in this lady, you can see that when she is standing erect, she's not standing perfectly straight. There is a definite truncal shift to the left. You can see she's not standing perfectly straight. So we know it could be from disc degeneration. Yes, there is some explanation of which way you can tilt, but this cannot definitely, you can't by this, because if you see on the top here, this is what is known as a shoulder presentation of the disc, and this is called the axillary presentation. That is, if you take the nerve root as arms, is the disc coming out here. But based on the way they are tilting, you can't imagine where the disc is coming out. But that used to be one of the methods. Here, the patient has got a clear-cut deformity. This is scoliosis. Scoliosis is not a side-to-side curvature, but a rotation of the entire spinal column. So that is why when you bend down, you can see there will be a rib hump and maybe sometimes a compensatory loin hump on the opposite side. So it's a S shape, but it involves the rotation of the spine. Whereas here, you can see there is truncal shift, but more importantly, you can see that the curve on one side is worse than the curve on the other. While she bends, you can see she's got an acute angle. Can you see that? At the lower thoracic spine. So she's got some signs of Sherman's kyphosis. That is where there is the end plates. So 3 adjacent end plates, there is vertebral end plate changes. So the vertebrae are blocks of bones. So they are bricks. They should be nice and parallel. But if 3 vertebrae are sort of crushed together, then or slightly, that is because during development they have not grown properly. So the brick has not grown properly. The front of the brick is slightly smaller than the back. And unfortunately, they are involved in accidents and they come to A&E, they have an X-ray and they say, oh, you got a fracture. Actually not. It is just a developmental this problem. So you can see here in this MRI scan that multiple vertebrae end plate changes are seen in this young, and they all converge together, and that is how they have that increased kyphosis there. In a normal, so when you try to test them, you can ask them to bend down and get up, and that would be a normal flexion extension. But when they have pain, they don't do that. They can't just flex and extend, they have to use their legs for their support. We say that is from the degeneration in the disc, or they have a black disc. You can see here there is a degeneration in the disc. That disc is black. It has lost its water content. The disc here are good discs. So this is the spinal canal. This is the MRI scan, spinal canal. These are the cushions or the intervertebral disc. This is a black disc. This is a good disc. But even if you have a black disc, you can compensate well with exercises. You can compensate well with exercises. And actually, if you exercise and the muscles are strong, you can prevent the deterioration of the disc. In my car tire, if my tires are not fully filled, then there's going to be a lot of wobbliness and there's going to be a strain on my shock absorber. Whereas if my tires are plump, then the rate of deterioration in my shock absorbers is going to be less. And with my patients that I'm going to show you, significant disc prolapses have resolved naturally. You don't need the orthopedic surgeon. Nature is on our side. You just have to do masterly inactivity and patients do get better. So here you can see a disc prolapse. You can see on this side the jam has come out of the jam donut. And here it is just contained. So here quite likely it is more only back pain, whereas here you're going to have a combination of back pain and leg pain, and mainly more leg pain. You may also have problems arising from the facet joint. If there is arising from the facet joint, they generally tend to flex forward to relieve pain, whereas usually if you have a discal problem, you're going to extend to relieve pain. I asked them range of motion, how do they flex, extend, so someone should be able to see their toes, they should be able to look directly above their head if they have full flexion extension, tilt their head on either side. Range of motion can vary, but you can't make it just a little bit more arthritic. Now, when I see MRI scans, patients tell me, oh, I've got degeneration in my spine. But, sometimes we over-medicalize things. I'll turn to them and say, well, you're 50 years old, your skin looks 50 years. Your skin can't look baby skin. If your skin is looking baby skin, I want to know the juice that you're applying to your face. So if your skin is 50 years, your spine is going to be 50 years. It cannot be that your spine is going to be 0 years. So degeneration is part of life. Your skin, there are a few wrinkles. And some women look at me, when I say, but that's natural. That's normal age-related changes. So some of the changes, we over-diagnose, over-medicalize things. All of you have had a shower this morning. All of you have brushed your teeth this morning. But if I look into your mouth with a microscope, what do you think I'll find? I'll find a jungle there. And when you're now drinking some water, you're drinking all the jungle into your tummy. But we may need that jungle. Are you with me? We may need that jungle. So we do the sensation, we see where the numbness is, and based on that we can decide which nerve is affected or which nerve is not affected. And general examination, the motor power in the lower limbs, it's you see lower down, if flexing the toes down is S1, greater toe up L5, ankle up, L4 tibialis anterior, keep kicking the knee straight is the L3, and flexing the hip is the L2 psoas. So there are 5 myotomes in the lower limb and 5 myotomes in the upper limb. These are things you know, that's why I'm trying to speed through. If you want to stop, you can stop. And there are muscle grading, MRC muscle grading, where 5 is normal, and 1 is a flicker of activity. Even deep tendon reflexes you can grade from sluggish, to if it is hypertonic, you can be clonus where there is repeat. And I'll show you some of the signs. I've read Idiot's Guide to Orthopedics, so easy way to remember. 1, 2, buckle my shoe. So S1 and 2 is the ankle reflex. 3, 4, kick the door. So the knee reflex is the L3 and 4, lumbar roots. 5, 6, pick up the sticks. Your cervical C5, 6, here's the biceps jerk. And 7, 8, lay them straight. So your triceps jerk comes from your C5, 6. There are special tests. Sperling's test is a way of turning, but again, these are all, you cannot make a diagnosis, because if there is pain, these are tests mentioned, maybe we ask them these questions. I also teach in the Liverpool School of Medicine, and there I have to demonstrate Schober's test. And I told the students, I daily see about 20 spinal patients. I've never done a Schober's test in the last 20 years. But I have to teach my medical students the Schober's test. So we have to do it maybe for historical reasons. So yes, Sperling's test is done to find out whether there is radiculopathy from the neck going down into the arm. As Ben said, you turn the head, provide axial compression. There's an image here, and then there will be pain along the arm. Then you can say that there is a disc bulge in your neck. I explained to you the difference between radiculopathy, where the nerve root is affected, or the A root, whereas myelopathy is the spinal cord is affected. A disc bulge, that is just a radiculopathy there, whereas here you have stiffness, you can see the tight compression, and there is myelopathy in there. You can see on the left the spine is compressed, whereas on another level where it is not compressed, there is adequate space. Sorry. Some of the signs, again I will show you some videos of it. Hoffman inverted radial grip and release escape, finger escape sign. I have some videos. So this is the Hoffman styles. There are many ways of doing it. One way of doing it is just flexing the tip of the finger. The other way is what I've shown you here, where you strike the DIP joint. It is, after all, a deep tendon reflex. Basically, you're suddenly extending the finger flexors. When you suddenly extend the finger flexors contract. This should not be, this is not a normal reflex. It only happens if you have myelopathy, or if you have multiple sclerosis or something. So it is normally not there. You will not be able to find it because you are not myelopathic, or you are not having an upper motor neuron sign. So this is completely a lower motor, and there is suppressed by your upper motor. Only if the upper motor is not able to reach the lower motor will this be positive. So if you have a compression in your neck, then you may get it. Does that make sense? This is the inverse radial. So when you strike on the brachioradialis, you should only contract the brachioradialis muscle. But in this lady, as soon as I strike on that, you can see the fingers are clenching down. So that is again shows there is a hypertonic reflex there. So this is called is everything clear, or am I not explaining things? Yeah. So this is an inverse radial reflex. Clonus. You should get more than 3 jerks is a clonus, and you can see here I'm getting a lot of jerks. So trying to lift up the ankle, so the tendo Achilles is working, and there is a multiple, the clonus, the beats on the leg. Straight leg raising, this is how you do a straight leg raise. So, or you can do it here by compressing inside the popliteal. You need to identify whether it is coming from the sciatic nerve. So I've got a video again here. So you lift it, say to 30 to 40 degrees. The patient has pain. How do we know whether the pain is from the sciatic nerve or whether it is coming from the hip joint or the sacroiliac joint? Sorry, this video is not working. I'll just go back. So how do we know that? So even if at 40 degrees you have pain, you lower it by 10 degrees. By lowering it by 10 degrees, you're taking away the stretch on the hip joint or on the sacroiliac joint. And then you're dorsiflexing the foot. By doing that, you're now only stretching the sciatic nerve. Have I made it clear? So then you can isolate it is coming from the sciatic nerve, because otherwise it just could be the arthritis in the hip. Sorry, the video is not working, I think. And then this is that is the sciatic nerve, the nerve coming from the back. Also, sometimes you can have a high lumbar disc prolapse when you can have a femoral nerve can be stretched. For that, you have to lie the patient prone and bend the knee up, and sometimes you can extend the hip. But in a lot of elderly people, this will be positive. But that is mainly from quadriceps contracture rather than the femoral nerve itself being compared. But we have to look for subtle signs. This is a young man, and I don't know whether you can see, I don't know whether it's clear on the image, but there is a patch of hair on his back. Can you see that? So that usually in the midline, if there is a patch of hair, it may indicate that there is some spinal dysraphism inside. So this gentleman has got a diastematomylia. I'm just trying to act as if I know a few words here. It's nothing. It's just that his spinal canal is split into two. Can you see the bony spur in the middle? So he's got two spinal cords, and that hairy patch was giving us an indication. He has otherwise no neurology at all. It is an incidental finding, no neurology at all. Now, what is this? This is a plank. Majority of my patients come and tell me I've got back pain. So then I say, well, and I find there's nothing wrong with them. Youngsters coming, 20-year-old. So I tell them, I ask, the conversation goes like this. I ask them, who's young, you or me? They look at my bald head and grey hairs and say, what is this guy? He's got mad. He says, you're old. Then I say, okay, fine. If I am old, then you're young, you're fitter, I'm an old man. Okay? Your physical prowess should be better than mine. They say, yeah, I can, fine. Let us do a plank together. You do a plank and I do a plank, and let's see who wins. And I can do a plank for 3 minutes. And usually there is a 20-year-old who can do a plank for 15 seconds. Then I tell him, well, the structure of the body is that you have the vertebral column, but the bones cannot stand up by itself. It is the muscles around. Unless the muscles are strong, the structure cannot stand up. If your muscles are weak, you can't. Can I go to a doctor to get a six-pack? Can I go to a physio to get a six-pack? Can I have injections or tablets to have a six-pack? No. Who needs to? You need to work. You need to get a six-pack in your back and build up the muscle. And that only you can do, no one else can do. And some of the plank is, I don't know whether you know that FIFA has an 11-point program. FIFA is a football. And in their 11-point program, there are 10 exercises. And there is evidence by doing these exercises, injuries in the football ground has reduced. These are not just for professionals. These are also for 5-year-olds or 10-year-olds who are playing football. And some of their exercises are similar to the plank. They call it the bench. So this is slightly more difficult than the plank because they're lifting one leg off. They're really standing on the toes of one leg, or even a side plank. These are the exercises. I would like to challenge you all to do a plank, but not now. And core stability helps, prevents injury. We know it. Even in kids who play, we can't think you can just go out and play. It is not possible. You need to do the strengthening, otherwise you're going to hurt. If you have an army and if you send the soldiers without training, they're going to get killed. You need to train them. Same way, you need a fitness to lift a newspaper from the floor. They expect it may just happen. It doesn't just happen. And you need to slowly. And this is the evidence which shows that FIFA 11 has helped. So these are the two cycles, the vicious cycle and the victorious cycle. So when you have pain on the left, you have the vicious cycle. You have pain, you don't move, the muscles become weak, less support for the bones, there is more pain. Whereas you can do the contrary, there is pain, you continue to move, stronger muscles, more support for the bones, and that is what we want. And we have the Liverpool back pain song, and I'll allow you to read that for a few seconds. Does that make sense? Or? Right, so that's the little book I've told you. You can read through that. And if you need more copies of the book, free copies, just write to me, and I'm quite happy to send those. Can I call first Roger, if you come along. Roger, just tell them what happened to you. Come along. I've got two patients. Come here, please. Yeah. Thanks. Thank you, Roger, for coming. Okay, come here to this mic. Yeah.
Last June I had a knee operation, and while I was healing I was covering a lot of mileage in work. I was limping a lot. End of September I got back pain. It slightly got worse, and come the weekend the pain went right down my leg, unable to get comfortable, sleep, sit. It was tough to stand up and go to the toilet. So I went to see a surgeon in the Spire who just said, yeah, we'll give you a nerve block. If that doesn't work or it'll work for a bit, we'll then operate. It was a bit cold, so I didn't like the way it was. I wanted to know a bit more. I've always been sort of looked after myself. So I got in touch with George. George sort of explained it a bit more. The key thing from George was he explained the need for patience. It's something you don't want to hear when you've trained all your life. But I listened, changed my goals, realised that it would get better, and I'm in a lot better position now. There was a lot of other side effects that come from having this sort of pain. Obviously not being able to exercise made me a bit depressed, but I got all sorts of nerve issues as well. But I think the fact that George was so patient, told me to be patient, was understanding and caring compared to another person I've seen, because I think if I'd stuck it out with that person, I think I probably would have been operated on by now, because it's just the difference. But I'm in a lot better place. I'm a little bit weak still, but I'm riding my bike again. My knee's healing. And George is the best person I've seen for it. So, he hasn't paid me neither. But that's where we are now. I get slight funny feelings in my leg now and then, but I just feel weak. But I'm getting stronger, and I'll get there, and I will. And that's it. That's where we are.
Thanks, you're not supposed to embarrass me, man. Now this is Lee's scan, and you can see a big disc prolapse here. Can you see that? Sorry, can you see the disc prolapse there? And now he's pain-free. He's pain-free. He's back at work. He's working. You know, I didn't do anything. And if you remember, the best thing in medicine is the creative art of medicine is the ability to entertain patients while nature cures the disease. So that's what we need to do. I've got one more lovely patient, and she's even more amazing. Belinda, can I ask you to come here, please, Belinda? I've got loads of x-rays like this. There was another one. Okay, I'll show you Belinda's also. Yeah. Thanks, Belinda. Thanks for coming. Tell them your story, Belinda.
Hi, yeah.
Sorry. Yeah.
I was in a car accident and I got diagnosed with a huge disc prolapse. I was in a lot of pain. And to cut a long story short, when I came into the Royal, the surgeon that I seen put me in a Philadelphia collar and admitted me for imminent surgery. I was in shock because I hadn't been diagnosed at that point, so it was a real shock. I just knew I was in a lot of pain, and I was experiencing cervical myelopathy and leg numbness and things. I was admitted, and on the morning of the surgery, I was like really intuitively sort of unsure about it. Just in all the possible outcomes seemed a lot more dangerous than you know, the sort of pain I was in. So I decided not to have the surgery, and I was supported by the surgeon. And through the car accident, I came in touch with George, who gave me the confidence to say it would heal naturally. That was my intuition. So what I done was just kept me all the things I was told not to do by two separate surgeons, you know, not move too much, things like that. I was more or less told the opposite, and that was my intuition, to keep moving, to keep stretching and things like that, which I did. I changed my diet and went really more of a holistic approach. So that's how I'm healing now, and it's been fantastic, you know, from going from a lot of pain and everything. I'm more conscious of my posture and things like that, so it's amazing.
Thank you. Thanks very much. I just, sorry, it's not my private practice promotion. I'm just showing you some patients, that's all. So they've been very kind. This is Belinda's neck. and she has got a humongous disc. Can you see that disc there? So that's her brain. That's the vertebral column, blocks of bones. In between the blocks of bones are the cushions. These 3 cushions are worn out. This cushion has come out. Can you see that? And this is the spinal cord and how much it is compressing the spinal cord. Can you all see that? And you can see this is the same cross section. So her spinal cord should have been sort of oval like this, but the disc has come out like this and pressed the spinal cord. Can you see that? And 2 independent surgeons very correctly, appropriately recommended surgery. But the difficulty in the spine is 1 in 5 land in disasters. There is 1 in 5 spinal operations result in a condition for failed back surgery syndrome. If you are flying by Saudi Arabian Airlines, every 5th aircraft was crash landing, would you fly that? Even now, 2 Boeings crash and they have grounded that. We should be grounding all spinal surgeons. Sorry. That's reality. How many people are dying from opiates we prescribe? We need to think. And look at Belinda's scan a year later, completely resolved. Not by surgery. You can see there is no disc prolapse there at all. By autophagocytosis. That is, your own immune process will eat the disc off. So we don't know, technically by giving injections of steroid, we are maybe preventing the natural resolution of the disc because the steroid is a strong anti-inflammatory. So we need to think whether we are doing, and maybe the old adage that we say, no gain without pain. Yes, you may need that inflammation, macrophages to come there, eat away the disc and gone. Magic. I didn't have to put a knife on her to get this result. So it can just be natural. So maybe it is masterly inactivity that you need in many of these situations. But they need to be, told how to build. So I'll just go back to the previous, sorry, I'm 5 minutes over. I'll just go back to the previous slide, Lee's slide, and that is also important. Sorry, where's Lee? Sorry. No, that's it. So there's another lady here also. You can see how she has got a big lumbar disc prolapse, and that is resolved within a year completely. And you can see the comparisons, disc prolapse after a year gone, and she actually used to play hockey for Liverpool University, and she was back. This is after the disc prolapse had resolved completely. Now look at Lee's MRI scan, and this is what I show. Everyone concentrates on the disc bulge, but I concentrate on the muscle around. This is subcutaneous fat. All of us have it. I have lots of it. But here is the muscle that holds your spine up. Can you see this? The dark is the muscle. The white is the fat in the muscle. So there is fat infiltration of the multifidus muscle. I make it a point to show this to the patient, and I say, this is where you can change. You can build up this muscle. You can convert this fat to muscle. Only you can do it. I don't have an injection or tablet to do it. You need to do it, but surely and slowly. I have a snippet later on how to tell about exercises. I'll give you some snippets, but now I think it's time for having a break. All our breaks are nice beverages and food, and they're all plant-based. So Joe Oates is catering for us. So you can now have your morning break. Thank you for,